Alrighty, 2:03 Eastern Time. That is my signal to begin. So why don't we do that? Thank you everyone very much for joining the Association for Psychological Science for PSPI Live, which is a special virtual event series that features articles published in APS's journal, Psychological Science and the Public Interest, or PSPI. My name is Andy DeSoto, and I'm the Director of Government Relations at APS. And if you don't know our organization, we're an international society of psychological scientists and students of research psychology who are dedicated to advancing the field for the benefit of science and society. If you aren't yet a member of APS, we hope you'll consider joining us by visiting psychologicalscience.org. Today's PSPI Live is going to be really great. In this program, you'll hear a review of the recent PSPI publication, Psychological Interventions for the Treatment of Chronic Pain in Adults, followed by further perspectives by experts in this area who you'll meet in just a few minutes and who are on the screen with me right now. Before we get started though, just a few quick logistical details. Today's webinar will be 60 minutes in total. As attendees, your cameras and microphones will be off for the session. So to interact with our panelists, I encourage you to make use of the question and answer box that's at the bottom of the screen to submit your questions. I know that some attendees also submitted some questions in advance, which I believe that some of our panelists do hope to address those questions if they're able to today. So you know, today's video will be recorded and will be made available a couple of weeks following today's session. But without further ado, I'd like to introduce APS William James Fellow Nora Newcombe, PhD, who is a Laura H. Carnell Professor of Psychology at Temple University. Among her many leadership roles in the field of psychological science, Dr. Newcombe serves as editor of Psychological Science and the Public Interest, and she commissioned the publication that you'll hear more about today. Dr. Newcombe's research explores cognitive development and adult cognition broadly, focusing on memory, navigation, and spatial thinking. As editor of PSPI, she'll also serve as the host of today's special program. So with that, Dr. Newcombe, I will turn it to you to introduce today's topic and our panelists. Thank you very much.
Thank you, Andy. Thanks for arranging this and for all your support along the way. And it's a real pleasure to be editor of PSPI. You may have wondered as you heard about cognitive development and navigation and episodic memory, what do I know about chronic pain? And the answer is nothing. Thankfully, I actually don't have chronic pain, although I know many of you do or will have relatives who do. It's a very, very common problem. But when I became the editor, I sought advice about issues in life, in public policy, that psychology has the wisdom and the knowledge to address. And what PSPI tries to do is to bring together what we know about topics where the public and policymakers want to know what at least the current bottom line is on the kinds of things they care about. Someone suggested chronic pain to me and non-pharmacological and psychological treatments. So I eventually found my way to Bob and Mary, who are part of the author team, and they will present for about 10 minutes. And then we will have a slightly shorter commentary from Dr. Shari Ling and from Christin Veasley. So let me tell you about all four of them at once so we can go from person to person pretty seamlessly. Bob Kerns is a clinical psychologist who's spent kind of his whole life, I think, trying to address the problems of patients with pain. He's a professor of psychiatry, neurology, and psychology, and a Kerner Fellow at Yale University, and a program director of the National Institute of Health, Department of Defense, Department of Veteran Affairs, Pain Management Collaboratory Coordinating Center. Oh my goodness, that is a long, long title. So he has a strong record of federally funded research on pain management, focusing on comprehensive pain assessment and non-pharmacological approaches. Mary Driscoll, PhD, is an assistant professor in the Department of Psychiatry at the Yale School of Medicine and a clinical research psychologist in pain research, informatics, multimorbidities, and education Center of Innovation at the Department of Veteran Affairs. Yeah, more of a mouthful, Connecticut healthcare system, and a national pain consultant for the VA's Women's Healthcare Services. And she also serves on the Healthy Women's Chronic Pain Advisory Council. Shari Ling, MD, is the Deputy Chief Medical Officer of the Centers for Medicare and Medicaid Services, CMS, as you see there in her background. And she contributes her clinical expertise to CMS as a geriatrician, gerontologist, internist, and rheumatologist, supporting their actions to improve healthcare outcomes for beneficiaries, families, and caregivers. She serves as the leader of the CMS Behavioral Health Steering Committee. And Chris Veasley is the co-founder and director of the Chronic Pain Research Alliance. Her health experiences with chronic pain have led to her life's work as an advocate for the acceleration of rigorous multidisciplinary pain research and the translation of research findings into meaningful change for people with chronic pain, with a special emphasis on pain that occurs in women and the kinds of pain that frequently co-occur. She has advocated congressionally and at the federal level about public awareness of the impact of chronic pain and the need for an increased federal research investment to address this public health crisis. So at this point, I will turn it over to Mary, who will give a short presentation summarizing the report that her team, the team she led, produced. And Bob will chime in towards the end. Thanks.
Thank you so much, Nora. Let me go ahead and share my screen. And is this working? Okay. Well, we're thrilled to have the invitation to be here today to discuss our recent publication. And I have to say that as an academic, I rarely have an opportunity to discuss the implications of my work in the real world. And it's something that I think as an academic, we really need to do more of. So I'm particularly pleased today that we're joined by Dr. Ling and Chris Veasley, and that today's audience encompasses such a diverse group of researchers, clinicians, advocates, and people with pain. So we're just going to give you a quick 30,000-foot view of the manuscript so that we can move on to a lively discussion about the implications of our findings for pain treatment broadly and psychological pain treatment more specifically. But before I get started, I just want to take a moment to thank my co-authors, Drs. Edwards and Becker, Ted Kaptchuk, and of course, Dr. Kerns, who is also my mentor. A special thank you to Dr. Beth Darnell for the thoughtful and commentary that accompanies the manuscript. A special thank you to Dr. Newcombe for commissioning the piece, and to Dr. DeSoto for organizing today's event. And then finally, I would be sorely mistaken if I didn't thank the vast community of scientists who are responsible for developing and evaluating the psychological interventions for chronic pain on which this manuscript is focused. And this work spans almost 70 years of expertise. So the manuscript itself, so before I get started, I should say that the statements and opinions in this presentation are my own. They do not reflect those of the Department of Veterans Affairs or of Yale University. But just to give you a broad view of the scope of the manuscript, it was commissioned to achieve several aims, the most important of which was to provide a comprehensive scientific lay of the land with respect to psychological interventions for chronic pain in adults. And within this, there were several objectives that we had. First and foremost, to summarize contemporary perspectives of chronic pain that underscore the importance of psychological interventions, to review the theoretical and empirical foundations of psychological interventions for chronic pain, to provide a narrative review of the evidence for these interventions, to evaluate factors that may influence the effectiveness of these interventions, to identify scientific and clinical practice gaps that may limit their uptake, and finally, to discuss strategies to advance the science and practice of these interventions. So probably most of the folks here are familiar with the biopsychosocial model, which is the predominant contemporary model of chronic pain. But for those who may be unfamiliar, I just want to give a brief nod to it. So this model was originally introduced in 1978 by George Engel, and it really emphasizes the interrelatedness of biological, psychological, and social factors in the context of disease and health. When we apply it to pain, it really encourages us to consider emotional, cognitive, and behavioral aspects of pain over and above the salient neural and biological processes that we typically think of. And this model allows us to simultaneously consider disease-related precipitants alongside a wide range of psychosocial factors that can predispose pain or serve to exacerbate it. And I love this model in part because it really helps us to understand and account for the wide variation in pain intensity, functioning, and emotional distress that we can observe when we have two individuals with similar levels of disease, but who have very dissimilar presentations. So for example, we may have two elderly gentlemen with similar degrees of moderate spine disease, and they have very different experiences. The first of whom may have a lively social life and great family support, and he may experience very little pain and only mild interference. Another gentleman with less support who may have just lost his spouse may have more pronounced disability in the setting of pain. And so we can also think about the biopsychosocial model as a systems model. And what do I mean by this? Well, by design, changes in one of these domains can precipitate changes in others. So an increase in stress may trigger inflammation, which in turn can trigger muscle tension, pain, emotional distress, and reduced productivity or social isolation. Likewise, improvements via targeted intervention in one of these domains can translate to improvements in other domains. So the biopsychosocial model clearly postulates a role for psychological factors in the expression and maintenance of pain. And by extension, it calls for psychological interventions in the treatment of pain. So the demand for psychological interventions for chronic pain is largely fueled by pain's role as a staggering public health problem. So 20% of American adults report pain that is chronic in nature, and almost 10% report high impact chronic pain, which is the type of pain that limits work or activity on most days every day. It also has a tremendous financial burden. Even though psychological interventions have been around for 70 years or more, around there for chronic pain. In 2016, the Department of Health and Human Services published the National Pain Strategy. And among other things, this National Pain Strategy asserted that the role of biopsychosocial factors as relevant for chronic pain, and called for integrated, evidence-based, multimodal, and interdisciplinary treatments that address these factors and include psychological interventions. And this report also called for the importance of safe and effective treatment options that take into account individual differences. Simultaneously, the CDC published a guideline for prescribing opioids for chronic pain, which also called for an increase in safe, effective, non-pharmacologic interventions for chronic pain. So again, even though psychological interventions have been around for a really long time, there's been a renewed emphasis and focus in the recent past. So this is a list of the interventions, psychological interventions for chronic pain that were included in the review of our manuscript. And of course, this is not completely exhaustive, but this is what we included. Some of these interventions, like supportive psychotherapy, focus on non-specific psychological constructs like interpersonal validation. Others, like CBT, target pain itself via the acquisition of things like self-regulatory strategies. Interventions like mindfulness aim to disentangle the tight connection between physical pain and emotional suffering. And then others focus on underlying processes like trauma or emotional avoidance. And all of these interventions aim to attenuate some subset of psychological risk or to augment some psychological protective factors. Many, like CBT and ACT, have been tested across a broad array of conditions, outcomes, and timeframes. Others are less widely studied and have varying levels of evidence. The important point is that all demonstrate clinical benefit. The largest body of literature on psychological interventions focuses heavily on musculoskeletal pain, migraine or headache, back pain, and arthritis, but there is evidence for other painful conditions, things like neuropathy and MS. Most importantly, in our examination, there's no reason to think that any of these would be contraindicated for any specific condition. So what was the take-home message? Really, it's that to a greater or lesser extent, psychological interventions for chronic pain convey benefit. And because psychosocial factors are implicated in the pain experience, care plans that exclude psychological interventions are ignoring a critical maintaining factor in the pain experience. Additionally, our work demonstrates that patients really should feel empowered to engage with whichever intervention appeals to their interests and needs. Likewise, providers should be confident that recommending any of these psychological interventions to patients should yield improvements in pain-related outcomes and quality of life. So at this point, Bob, I'm going to turn it over to you to just talk a little bit about the barriers that we identified.
Well, thank you, Mary. And again, let me add my appreciation to the sponsors of this podcast and to all of you who are joining with us today. Very briefly, I want to harken back to seminal reports from the Institute of Medicine published in 2011 and the national pain strategies that emerged soon after that publication based on a recommendation from the IOM that really did a nice job of outlining these many barriers to access for psychological interventions for pain across the domains that you see here. And there are overlapping barriers across these groups. Fundamentally, I think at the level of the patient provider and even at the level of administrators and health policy advocates, just a lack of knowledge or awareness of even the presence of evidence-based psychological interventions is a significant barrier. This may not be surprising because we understand that in professional schools, including medical schools and other health professions, let alone in public education, pain is either not addressed or under-addressed. And when it is addressed, it's historically been postured as a more biomedical reduction, in the context of a biomedical reductionistic model that does not attend to psychosocial factors to any great extent, let alone the potential value of psychological interventions. Beyond this, for many patients, the consideration or suggestion of psychological interventions that could benefit them are common responses, one of concern, of stigmatization, frank rejection of the idea or the implication that their problem is psychological or all in their head. And so stigma and bias against these kinds of interventions that of course are fueled in our culture through a pretty constant bombardment about medical medications or medical interventions that could be used for pain management, with the relative exclusion or almost total exclusion of any attention to psychological treatments. Beyond this, there are burdens related to access. Patients, even if they are aware of this, have a difficult time tracking down these kinds of the availability of these resources. And this points to an important issue that I would want to emphasize and that we talk about in the article as well, which is around observations of differences and frank disparities in terms of access, which unfortunately in terms of predictors of those disparities overlap considerably with what we know about social determinants of the prevalence of even chronic pain. At the provider level, I've kind of already touched on some of these, but I would say, in addition, providers work in an environment where other, particularly in non-government entities, organizations like the VA, where the incentives are really about volume-based, procedure-oriented approaches, and fail to really incentivize psychological approaches. So providers are vulnerable to those incentives. And I think extending this to the level of the system, organizational leaders, some of the same problems or barriers apply there as well. What we need is really a concerted effort around policy and working within organizations and we'll be excited to hear from Dr. Ling in a few minutes to try to change some of these barriers or mitigate some of the barriers moving forward. And then Mary, move on to the last slide. I'll just make a couple comments about future directions. I'm that one of those long titles. I'm involved in a very important tri-government agency sponsored initiative, the Pain Management Collaboratory, which in fact is supporting the conduct of pragmatic, even hybrid implementation trials that incorporate a broad array of non-pharmacologic approaches or models of care that integrate these approaches, including psychological approaches. Greater attention to pain in the context of the person, really shifting the focus from pain per se to the person with pain, with multiple co-occurring pain conditions and multiple commonly occurring medical and mental health conditions is important. We need to work on optimizing access to these kinds of interventions and to try to promote their sustained benefit over the longer haul. We need to be focusing on developing new interventions that are theoretically informed and hold the promise of breaking a barrier in terms of effect sizes of the interventions that we have today. And we need to focus on special populations, particularly vulnerable populations that I've already suggested. There's a lot of movement in the world of pain and tech and the development of technology solutions to enhance our psychological approaches. And finally, I think we appreciate that historically the focus on pain intensity as a primary outcome has failed to take into account important domains that are outcomes that are important to patients, like improving functioning and quality of life and improved emotional well-being. So with that, I'm going to close. I'm looking forward to the discussion, and I think I'm going to hand things off now. Here's the last slide with the resources, the commentary from Dr. Darnell, and then our paper. There'll be others, I think, maybe in the chat. But I'm going to turn things over now to Dr. Ling for her comments.
Thank you, Bob and Mary, and welcome, Dr. Ling.
Hi, good day. And first of all, let me just say it is indeed an honor and a privilege to be with you all today. And thank you for the kind invitation. And I actually don't have any slides for you, but I just want to keep my remarks brief. And to give you a little bit of background of the role that CMS, Centers for Medicare and Medicaid Services, plays in the implementation of programs and policies really that are highly dependent on the evidence and the knowledge that those of you who are researchers and scientists and with great thanks, to Bob and Mary for articles such as this, which actually are foundational for future programs and policies for implementation. But a word on CMS. So just by way of context, so CMS is the largest purchaser of healthcare globally. And so our programs and policies touch upon roughly 155 million people. That is 1 in every 3 Americans. And, the work that we do cuts across Medicare, Medicaid, and marketplaces, each serving the population of beneficiaries in a unique way, but all predicated on evidence that we can build programs and policies upon. So our vision is to really serve as a trusted partner and steward and advancing and expanding coverage and programs in ways that really enable achievement of better health outcomes for the people who we serve. Now, this includes, importantly, as Mary earlier alluded to, addressing physical conditions, which are multiplicative, but also cognitive and mental health conditions. And better pain management requires that care and service happens with a focus on individuals in that we really hope that the science can support important conversations so that clinically the right treatments and services can be recommended and implement for each individual patient, because there is no one, there's not a panacea for pain management nor behavioral health conditions. So the work that you do and the questions that I've seen through the chat really start to get at, so what works for what kind of patients? Is there one that works best? So however you build the evidence, be sure to know that we will be paying attention. So why is this conversation and the work that you do so critical? And how does CMS work to build on the evidence? And some of the policy programs and levers, just to briefly mention, include coverage that provides important and critical access to care and services, payment for those services, quality measurement and reporting, and all evolving to a state of payment that focuses on value as opposed to volume of care and services. And value must include quality as well as cost, focusing on health outcomes that we all would love to see attain for the people who we serve, our patients, our families, our colleagues. So, we are ever mindful that the Medicare, Medicaid, and marketplace payment domains actually serve people with multiple conditions that happen all at once. So as you think about the work that you're doing to demonstrate what works for management of pain, the opportunity to influence and provide evidence to enable access to cognitive therapies, cognitive behavioral therapies, approaches that actually could be any and all of what Mary had laid out in her slide, but also know that the question will come, so in what populations should they be best and most effectively applied? So why am I here today? I need you to know that effective pain management, effective management for people with chronic as well as acute pain has been included in the CMS behavioral health strategy. It is a designated and specific goal, specifically goal 3 of the strategy. And part of this, and thank you for putting that into the chat, part of this work also acknowledges the importance and that some of the impediments and barriers that Bob has already alluded to. We have actually interviewed and listened to both people with lived experience living with pain, whether acute or chronic, and also people who provide care and services to our beneficiaries living with acute or chronic pain, and have identified some really important evidentiary gaps. But as was said earlier, the evidence is pointing more and more to the importance of an integrative, comprehensive, multimodal approach that can include cognitive interventions. So all in all, this holistic approach, this person-centered approach really can serve the populations who we care and really come to work to serve in a very effective way. So I will close by just saying that CMS works by way of often rules, that is rules that are about payment or coverage, and all of those rules are published in the Federal Register, which is not a common place for people who are in academics and science to be perusing. However, it is a vehicle that we notify the public of what our thinking is about care and services, coverage, payment, and it is the opportunity that each of you, each of us as public citizens can comment on any aspect of what we propose through rulemaking. And CMS is obliged to listen and acknowledge each and every comment. And those comments that you provide CMS and policymakers with the opportunity to, it's called logical outgrowth, to actually adapt what is proposed in a way that is better suited to meet the needs and the intent of the original proposal. So with advance thanks for the time and all of the work that you do, I will turn it now to Chris.
Yes, thank you so much, Shari, and on to Chris for the patient and lived experience perspective. I think Chris just disappeared from the screen. She had alerted us there might be some connectivity problems where she is. I wonder if we want to go on to begin to address some of the questions that are coming in, as well as there were quite a lot of advanced questions. Mary and Bob, I know you had a look at the advanced questions. Have you had a chance to also look at the chat? I think there may be some overlap, but maybe just pick one that you want to tackle while we wait for Chris.
Mary, do you want to try to answer the question about what problems seem to respond best to which approaches? Are there combinations of treatments that are particularly effective? If not, I can jump in.
Sure, I guess I can start there. I think that this is the question that we all have, is what works best and for whom, which is really where I think the science is moving. So we have, from the manuscript and the work that countless researchers and academics and clinicians have done over the years, we know that all of these psychological interventions are convey benefit to a greater or lesser extent. What we don't know as well right now are what works best and for whom. And so that's really where we're moving. Certainly there are, within the manuscript, we highlight descriptions of the different interventions. And so there may be things that appeal more to certain problems than others. So for example, I can speak to CBT, which is really more of encourages the development of the acquisition of self-regulatory strategies to manage pain. And so this could be really beneficial for any painful condition where someone's having vacillations in their productivity from day to day, and for whom they may be withdrawing from, activities that previously brought joy or benefit. And so for that reason, someone might move more towards that. I'm thinking of one of the newer psychological therapies that's gaining traction, emotional awareness and expression therapy, where there may be underlies of trauma or emotional avoidance that are highly related to the pain experience. And so for folks for whom that may be a more predominant aspect of their presentation, moving in that direction may be more beneficial. But I think in terms of the scientific question of what works best and for whom, the NIH HEAL initiative and some of the backpack trials are actually using some optimization methodologies like SMART trials and MOST trials to really try to get at and answer those questions. So I don't know, Bob, if you disagree or if you want to add anything.
No, I think there have been some efforts, trials that have been organized using some of these designs, and it's still, I think, a largely an open question. In terms of who it works best for, I do think it's important to acknowledge that there was a large literature across these treatment approaches where the study populations are a more general, heterogeneous population of people with chronic pain, often with multiple pain sites and even conditions, let alone mental health or other medical comorbidities. And so they give us a good evidence that they're a little more pragmatic in that way in terms of the population being studied or sampled. And I guess it gives us a little more confidence about the potential benefit for a broader array of people. Beyond that, The condition that's been most studies is low back pain or maybe osteoarthritis secondarily. But, as Mary, I think, said, and maybe I mentioned a little bit, there's some literature across a much broader array of conditions. And so if you are somebody working or have a specific condition, I think it is worthwhile looking into the literature for what evidence there is for that particular pain condition. The other part of that question was about sequencing, and really, as Mary said, the studies that are happening now are moving in the direction of things like smart designs or specifically examining these kinds of care models and sequencing of approaches, even not just psychological approaches, but in the context of other approaches. And that's a major focus of some of our studies in the Pain Management Collaboratory that I referenced. So, the data are coming in, federal sponsors are funding this kind of research. So your question is right on target in terms of some of the most important scientific knowledge and practice gaps that are the subject of current research.
Can I just jump in with one more thing?
But we did get Chris back, so.
Well, let me just, just putting on my clinician hat when I respond to this, I also think that, the best intervention is the one that a patient or a person will actually utilize. And so if we have confidence that any of these interventions can convey some benefit, allowing some autonomy and descriptions and allowing the individual to have some agency in terms of what they select is probably going to lead to the best outcomes.
Good point.
One more point, and I bet Chris will say
Bob, this. Sherry wanted to say something.
Okay, go ahead, Sherry.
Right.
So just to also say, when it comes to Medicare in particular, because there are some statutory requirements as you plan your studies. And if you think that you would want something, a treatment or service to be covered by Medicare, please include beneficiary population relevant and recruit. So that the population studied looks similar to the population in which the policy would apply. I think it's just a common reason or gap in the evidence that I take every opportunity to raise. So thank you so much.
That's
Over.
Great. Thank you. Let's move on to hear from Chris. Thanks for your perseverance and getting back in. So please go ahead.
Yeah, thank you. Of course, I had no problems until Shari was just wrapping up and then it left. So I apologize for that.
Always the way.
Can you hear me okay? Great. So thank you, Nora and Mary and Bob, for the invitation to participate in this really important webinar today. And as you mentioned in your introduction, I've spent my life advocating for the improvement and acceleration of rigorous pain research and thinking about how do we translate that and implement it into improving the lives of people who suffer from chronic pain. And so when we were talking about this actual presentation, what I thought about is, well, if we have really good evidence for psychological interventions, why are they not being more utilized or implemented right within the clinical system? And obviously Bob touched on many of the barriers, as did Shari, in terms of why we don't have more implementation or translation into the clinical arena. But and obviously there's multiple systems barriers as well. But I thought I would just focus on two in particular from the perspective of a patient and an advocate, since I do have 30 years of lived experience with chronic pain. And the first really relates to stakeholder engagement in the actual planning and conduct of research, right? And Shari talked about this a little bit as well, and the importance of really thinking from the very genesis of your study, who will be all of the end users of the data that this study will generate, whether that's payers, healthcare systems, whatever types of clinicians, patients, caregivers. I mean, there's a long list of potential stakeholders that will be using the data, and then incorporating them from the very genesis of the study, right? From the very beginning of the study, getting their perspective. As Shari mentioned, for CMS to make decisions, coverage decisions, the data has to be on populations that they serve, right? And they also need cost and quality data, right? But a lot of times people are not including that in their studies, and you can't ever go back and redo a study without getting new grant funding and replicating it, right? Which no one is going to do. So it's really beneficial to bring people in from the beginning and get their perspectives on how they will use that data so that you're better able to plan your study and design it and conduct it in a way that maximizes the ability for that data to be utilized, right, in the end. And obviously that includes patients as well as caregivers and getting their perspectives. A lot of times when people plan studies, they think about getting patient inclusion or stakeholder inclusion to think about how they increase recruitment and retention, but there's so many other things that go into creating a meaningful study that will generate data that's actually meaningful to people who will be using the data that come out of that study. And the second part that I wanted to mention, which ties into this, is really about inclusion. So the first point was that inclusion matters, right? The second point is that language really matters. And Bob touched on this a little bit in terms of some reasons why there isn't more of an uptick in utilizing psychological therapies from a patient perspective. There's so much stigma and bias around pain to begin with, and a lot of the other comorbidities that Shari mentioned as well. People with pain have multiple comorbidities, including mental health disorders, sleep disorders, TBI, you name it. There's just a long laundry list of other chronic health conditions that people with pain have. And a lot of times throughout the journey, most people with chronic pain do not get diagnosed quickly. It takes them a long time consulting a number of clinicians before they actually get a proper diagnosis. And along the way, whether it's intentional or unintentional, many patients either receive or are directly told that their pain is in their head, right? Or they're making it up, or they're malingering, or they're drug seeking, or whatever. There's many reasons as to why that happens. And so then when they do get to a clinician that talks about the importance of incorporating the biopsychosocial model and psychological therapies into their treatment, which is absolutely right to do, right? To understand and be educated about the fact that the mind and the body and your social determinants of health all play a role in your overall well-being and health. But what happens is that there's a triggered response in patients. Oh, this person is telling me again that my pain is all in my head or it's not real. Rather than educating the patient and family members about what actually that means, right? What are psychological interventions? It's not saying that the pain is all psychological, that it's not real, right? But it's saying that our psyche plays a role in our health and wellness, including in the management of chronic pain. And a lot of, so I guess what I would say is that language matters in terms of how we're talking about psychological interventions, both from the perspective of educating, a lot of times we talk about it as neuroeducation now, right? Educating people about the role of the biological, psychological, and social interventions and how all of those things impact your brain and the health of your brain. And then also being very clear in our language that we're not blaming the patient, we're not suggesting that their pain isn't real, but really highlighting the important role that psychological interventions play, which I think will have more of an acceptance and uptick in the patient community in terms of incorporating important psychological interventions into their entire toolkit for chronic pain management. So thank you very much. I look forward to the discussion.
Yes, thank you so much. There are questions pouring into the Q&A in addition to the ones that were advanced questions. And I have to apologize in advance because we aren't going to get to all of them. There's one in particular for Shari. I don't know if she's still with us. I know she had some places she had to go. Shari, are you still here? There's one for you about current CMS initiatives.
Yes. So yes. So I think just to keep it brief, we have been learning a tremendous amount of how care it can be implemented by way of telehealth, but have also been able to extend coverage by way of telehealth for in the mental health space by way of the Congressional Appropriations Act. I think it was CAA. So again, there's a rule or a statute, a law that, you know, dictates CMS to implement, develop and implement in a certain way. I think, you know, the access to care and services overall has, you know, telehealth has been a successful vehicle to enable access. I think the challenge is a couple-fold, that, you know, we are learning that the solution is not either telehealth or in person, but likely that a hybrid for us to rethink how care could be delivered, perhaps segments by way of in-person versus by way of telehealth. And I think we are all eager to learn the extent to which those care and services are, how we would look at not just access, but access to high quality care and services. And there is a lot of work underway to understand and be able to measure quality of care that isn't about a score on a, you know, piece of paper. We have learned how challenging the dynamics can be, and misuse of certain tools. So we have also really sought to understand telehealth from the beneficiary or the patient's perspective. Not everyone can access telehealth. Ironically, even some localities that telehealth was designed to solve a problem of access for. But use of technology does not come easy to everyone. So I think there is tremendous opportunity and need to understand, how do we make it easy and effective at the same time, so that there can be clinician-patient engagement. So I really appreciate the question. And the other part of the question was about parity. And I will suffice it to say that there are certain aspects of parity that CMS is required to address, that will all be forthcoming in rulemaking, the what and the how. As we think about that and see that unfold, I think there is even more opportunity for us to think about how do we better integrate physical care of physical things with care of mental health things. So integrated care that actually should improve outcomes in a more effective way. So thank you for the question, and thanks for the extra time. Over.
Great, thank you. I thought maybe we could move to a question that's come up a few times in various places, which is, this report is about chronic pain. To what extent does it extend to acute pain, or is that just a very different thing? I think acute pain's come up a few times in this discussion as like together. Are they just sort of the same except one lasts longer, or what?
Bob, do you want to take that, or do you?
I put a few comments in the chat or Q&A already. I think it's the literature on psychological factors or psychosocial factors and acute pain, you know, is a long and old literature that extends into the laboratory setting and then into clinical settings as well. So this is important in our foundational understanding of the experience of pain and now accepted definitions of pain that really I think overall emphasize that it's a personal subjective experience, and it's not too far a leap, I think, from that kind of statement to acknowledging, of course, that what we've known now for decades, which is the important role of our thinking and feeling, if not our social context, environment, social responses, significant others, all of this influences our experiences of pain, including acute pain. So a lot of our knowledge about these factors grows from our understanding of pain in the laboratory and acute pain settings. Having said that, most of the advances around psychological interventions have really been around chronic pain and chronic musculoskeletal pain. I think Mary already emphasized that. Much less is known about some other chronic pain conditions, most notably and commonly other neuropathic, what we call neuropathic pain conditions, nerve pain, like that associated with, for example, people with diabetes who have neuropathy and who develop pain in their extremities. But looking at the acute pain literature, the exciting thing I emphasize is that although the literature is slim to date, there are people that are specifically zooming in on this opportunity, somewhat fueled by attention to the opioid prescribing and a move away from prescribing opioids, even in or limited prescriptions of opioids. The concept of opioid sparing effects of interventions in the acute pain setting, limiting access to opioids, has fueled, I think, several investigators and a growing interest in sponsors to fund research on acute pain management, including psychological and other non-pharmacologic interventions. And so we've already cited Beth Darnall for her commentary. I think I can't recall if she mentioned this work. I think we asked her to remove it because it wasn't specifically relevant to the chronic pain discussion. But she, I'd single her out as doing some really wonderful, rigorous research, building an evidence base for brief or even ultra brief psychologically informed interventions in the peri-surgical setting, particularly, I think, women with breast cancer, but some other populations as well. So it's stay tuned. I think there's, not that we're done building the evidence around chronic pain, but there is increasing focus on acute pain, and with the idea of course, trying to intervene to effectively manage pain in those settings, but also prevent the progression to chronic pain. And in that context, the overuse of medications like opioids.
Chris wants her name in the chat, or not this Chris, a different Chris. Beth Darnall, Darnall. Someone could put it in the chat perhaps. And she wrote a commentary. We have only 4 minutes left, so maybe one more question. Mary, Bob, Chris, Shari, is there one question you want to hop on right now that you think is most important?
I'd like to speak a little bit too. There was a question in the chat about motivational interviewing and getting people to engage in non-pharm treatment, and the reluctance, which I think Chris gave a nod to in terms of the language that matters. And I think the language matters. I think also when this is introduced to individuals is really important. So I also think that a lot of what's going on in the with the shift away from opioids, I think there are many providers who aren't convinced that this is important. And so they're feeling like this is all they have to give, and they don't have a lot of faith in it for whatever the reason. And so they may not be convincing in their language, or they may not understand very much about how these interventions function or are part of the care plan. And so I think sometimes they're not delivered in ways that are particularly helpful in terms of the language that's used, or even in terms of the stage of treatment at which they're offered. So we often see these these interventions delivered much later in treatment after, I think Chris, you had pointed to the longer time to diagnosis. We see this a lot with women, especially with chronic overlapping painful conditions. And so when you wait longer, it kind of comes as the booby prize. Well, we couldn't figure out any of these other things that worked for you, so here, have this. And so, I think to piggyback what Bob said too, when we talk about the transition from acute to chronic pain management, this is a conversation that this is a pillar of your pain care. This conversation needs to be happening earlier in the chronic pain trajectory, so that people are aware of the way these factors influence their pain, and that they can seek this care. I think the other thing is there's a lot of gatekeeping. So this is, you need a referral from somebody who knows about it to someone else. So increasing access, in many of our chronic pain trials, our best tools are allowing direct marketing to the patient, which doesn't actually happen with this kind of thing. You need a referral. And so, really seeing if we can get this closer to the patient, directly marketed by the people who provide it, who may be able to use language that is more appropriate. So I'll stop there, but those are just some thoughts.
You need like a TV ad, get your mindfulness treatment here.
Or, even just letters from, so in our healthcare system, we can send letters to patients who are particularly,
Okay.
who could benefit.
I do think a public health messaging campaign there have been several successful campaigns around the world in other countries, but not here. So looking for opportunities for funding and advocacy to try to push that agenda. I want to make one other comment. I know we're out of time, but I'm aware that this is a psychologist audience and many in academic settings. Just as our medical colleagues and other associated health professionals are responding to calls for attending to pain in our education programs, graduate training in particular. This is a shout out to all of my colleagues about psychology getting on board with such an initiative, especially probably in the areas of clinical counseling and don't forget school psychology, and the need to better integrate attention to pain, really, even from an important perspective, as the area of symptom research that has advanced the most. Bringing a focus on pain and pain management into the academic setting in psychology is, I think, an important priority that I want to emphasize.
Thank you. Thank you, Bob, Mary, Chris, Shari. Thank you, everyone. And thank you, Andy and APS, for planning and staffing and recording and all that other good stuff.